I would like to ask, just identify if you were here for the first half, please raise your hand, your electronic hand, that is. Okay, I'm seeing a couple of people raising their hands. Excellent. Very good. Very good. Now, there are a few people, it seems, that were with us for the first half who haven't come back from their break yet, but sometimes that happens. So you can put your electronic hands down now. Thank you for responding. So I'm going to actually ask you to answer a type-in question at this particular point. And this is the type-in question. Before we broke for the break, what percentage was transmission reduced? What was the finding of the study that we talked about before we took the break? Type in, if you recall, what the percentage reduction was. People are typing in 96, 97, 95, 96%. Yes, and somebody types in 96%, 2 exclamation points. Absolutely, that is it. So if you were going to tell somebody who didn't know anything about this study, and you were going to give them sort of what you feel is the important information from this study, what would you tell them? And how would you use the statistic in that? What would you tell them? And you can type that in too. This is a 102 question. So you're going to tell somebody about the important information from this study. You're going to use this, and somebody writes in treatment is prevention. That's true. Antiretroviral therapy is very effective. Absolutely. What would other people say? Thank you for adding that, by the way, those two. What would other people say? How would you use the statistic and share the information? We'll give it another minute or so, and then we'll see what we come up with. So what we have is treatment is prevention. That was offered earlier in part 1. That's absolutely true. And then ART therapy is very effective. Yes. So PrEP and or ART works in mixed diagnosis couples to reduce the risk of contraction of the HIV virus. Very nicely put. And again, you could use that statistic. Here's somebody using the statistic. You are 96% less likely to infect your partner if you are in treatment. Absolutely. I understood what you meant, that if you're in treatment. Absolutely. Very good. And again, I really appreciate that in terms of use of the statistic. Yep. Wonderful. All right. So we can advance. If the infected partner takes antiretroviral therapy, risk is reduced of infection by 96%. Excellent. And again, I really appreciate you focusing on putting it in this language because, you know, we can often get these results from studies, and this is a really powerful result. It's a very exciting result, and it can sometimes be very difficult to translate that into common language or language that's understandable to us and to our clients. So for your, you know, sort of using this webinar as an opportunity to do that, that's great, and the suggestions that you're making are wonderful. It has been proven that there is a 96% reduction in contracting HIV if you are on medication. Absolutely. You are protecting your uninfected partner. ART reduces transmission by 96%. Wonderful. All right, so let's move on to the next slide, which again gave us that great statistic. Now, prevention strategies, diagnosis and treatment of STIs. It is critical that we also get out this message. We defined that the message based on that study was that if you are indeed living with HIV and you get on highly active antiretroviral therapy, and you suppress your HIV virus, you are 96% less likely to transmit the virus. The other key message that I think we need to be able to offer our clients is that if you have some other STI, it increases the likelihood of your becoming HIV infected when exposed. So if you're familiar with that, if you've heard that idea, and if you use that idea with your clients, type in a Y right now. Excellent. So I'm seeing a lot of Ys. That's great. Wonderful. Good. So people are aware of this. Yes, good. Somebody says, yes, I've heard it. Okay, good. Now, if somebody says, well, why, and a couple of people are also saying that they hadn't heard of that. Yes, absolutely. Again, this is another key message that we would want to make sure that we get out. And again, when you have a sexually transmitted infection, it changes sort of the lining, the cells that line the vagina, the penis, and the rectum or the mouth, and ultimately it makes HIV easier to get into the body. And again, one thing that you want to keep in mind is, what is it that HIV does as soon as it gets into the body? What's the first thing that it looks to do? And you can type that in. Yes, it is looking to replicate, and it attacks a cell. Absolutely. It finds a host cell. And usually the cell that it wants to multiply, it wants to, absolutely. You all have this down. That's great. Ultimately, it wants to reproduce, and it needs a white blood cell, a T cell, in order to do that. Now, when you have an untreated STI, the body is working to fight that infection. So more of those cells are present in the area of the infection. Therefore, HIV has more of an opportunity to get into one of those cells. That's why it's critical to screen for and treat any other STIs. Now, the other point here, bullet number 3, is that people with both HIV and an STI have more HIV in their semen or vaginal fluid. So the amount of HIV is increased. And remember, in order to become infected with HIV, you have to have enough HIV to infect. Because keep in mind, sweat, tears, saliva have HIV in them, but not in amounts large enough to infect. So again, an untreated STI creates the opportunity for somebody to have more virus present or more opportunity for infection. So regular screening and treatment for other STIs is important in reducing the risk of HIV transmission. And again, this whole webinar is about sexual risk reduction. Now, this is the adult section of our webinar because we're using a graphic image, and I mean that in terms of a design image. Well, somebody writes in, kissing can transmit HIV. I'm going to respond to that before, and I'll let you enjoy this slide a little longer. But what I'll say in terms of kissing is that as far as I understand it, and Mary, please chime in here, as far as I understand it, transmission through kissing is virtually not possible. The only way that it could potentially be possible is if somebody had serious periodontal disease, serious gum disease, and or they had bleeding cuts in their mouth and they were kissing somebody else who had bleeding cuts in their mouth who was living with HIV. So the other sort of rule or guideline, not rule, but the other guideline that you can sort of apply to this is that continuum of risk that we talked about. On a scale of risk, kissing is practically 0 in the sense that think about it from the perspective of the number of people who kiss and the number of people that are infected with HIV. So kissing is not a transmission risk unless it's under very rare and very specific circumstances. So let's now move to circumcision. And again, I love this graphic because it shows how having a foreskin can actually create greater opportunity for someone to become infected with HIV during female-to-male sexual intercourse, heterosexual intercourse. And if somebody is circumcised, what this study has shown is that their risk is reduced by a full 50% of getting infected. And again, this image sort of explains how having the foreskin, the inner foreskin, is an area where HIV can enter. And when somebody has that removed, they are reducing the surface where they could potentially be infected. So circumcision is also considered a prevention strategy. And again, this can be a very complex one for a lot of cultural and religious and social reasons. And the data does show that there is medical benefit in terms of risk of HIV infection. And again, by a full 50%. So, harm reduction options for sexual activity. Well, first of all, the only safe sex is no sex. Okay? Abstinence is not having sex. Also, people can delay their sexual debut, meaning that they can wait longer before they actually have sex until they're older, and then they possibly make different choices. So abstaining completely or delaying sexual debut can be a way of reducing risk. Also, our friend mutual masturbation has returned. We talked about this earlier, and again, masturbation or mutual masturbation can be a way that people can have sexual activity and not risk infection with a sexually transmitted infection. This image, I think, is a really interesting one. I think it's interesting that the skin is shown as how it's shown, but basically what it's showing is that these behaviors do not allow, and this is an HIV viron, do not allow HIV to get through the skin. So that is what you're hoping for to completely prevent. But again, what did we say about exposure to HIV? You can be exposed but not necessarily infected. So again, keeping those things in mind. So harm reduction options for different types of sex. So let's start with anal intercourse. And whether you're a heterosexual engaging in anal intercourse or whether you're a same-sex relationship engaging in anal intercourse, lubricated latex barriers, condoms, the male condom and the female condom can be ways, and some men who have sex with men actually use the female condom for anal intercourse as well, can be barriers, latex barriers to prevent and reduce risk of infection. And again, this all touches on what you all wrote in at the very beginning about condom use, condom use, condom use. Vaginal intercourse, male condoms, latex or polyurethane, and female condoms again. And just a sidebar, that people in other countries, especially men, the quote-unquote female condom here in the United States is not sold as quote-unquote the female condom in other countries around the world, and men purchase them to use with their female partners as readily as women may use them here. A couple of people have written in, can you use, I don't understand that word, male condoms and female condoms at the same time. So yes, somebody's asking if you can use male and female condoms at the same time. It is not recommended to do that because the materials that the two condoms are made of can compromise the integrity of them, so it's not suggested to use them together. And somebody also writes in, and I'm glad that you noted this because unfortunately we don't have the time to go into all safer sex practices, but if you are using the quote-unquote female condom for anal intercourse, it's important to take out the removable second ring in doing that. And again, for oral intercourse, you can use a condom, usually an unlubricated one. They make flavored condoms, as I'm sure many of you know or maybe have used yourselves. And also you can make a dental dam for cunnilingus out of a condom by cutting off the tip and slicing it down the side. And or you can use a dental dam. People can also reduce their harm by the choice of activities that they choose to engage in, the degree of activity. And we're going to break some of that down as we move forward. All right, so I'm just about to turn this back to Mary, but other risk reduction strategies that people can use are, and I like this phrase, check out the merchandise, which means is that you want to look at people's genitals, whether you know them or whether it's a casual encounter, to make sure that there are no infections, lesions, any of that. Now, this can be challenging because sometimes women can have sexually transmitted infections that don't show up visibly. But checking out the equipment can be a way of preventing risk. Also, withdrawal before ejaculation can be a way of reducing risk. If you're familiar with the term dipping, and I'm just asking if you're familiar, I'm not asking you anything personal. If you're familiar with the term dipping, can you type in Y? So I'm seeing one Y, I'm seeing one N, another Y, some Ys, some no's. I'm not familiar. So it seems to be a little bit of a split. And again, we have 51 people. I'd love to get 51 responses. Okay, some people are saying that they're not familiar. Okay, so of the people that are familiar, would somebody tell us, and again, I'm seeing actually many more people as we proceed forward that are not familiar with dipping. Could those that are familiar with dipping type in what you would say is a brief definition of what dipping is? Again, you know, this is just to give a brief understanding of what is dipping, because clients may talk about this. They may even use that term. So what is dipping? And again, you can write that in, and I will read what you wrote, not identifying you, of course, and or I will throw out a definition myself, but I would prefer to start by hearing from you. Going once. Although you may be typing something and it might take long. Yes, somebody writes in, putting the penis into the vagina. And you added to that 1 or 2 strokes. Very brief insertion and withdrawal of the sex organ. Just the tip, in quotes. And somebody wrote in, not really sex. And it's funny, a brief insertion. It's funny that I appreciate that you framed it not really sex, because I've actually had the opportunity to talk with some younger folks about sex and sexual behavior, and many young folks today do not believe that oral sex is actually sex because it doesn't involve vaginal or anal penetration. So it's very interesting. Somebody also writes in, then putting the condom on before ejaculation. Absolutely. Again, you all could be leading this webinar. Somebody writes in, what about risk of tearing if either partner or both have penile or vaginal earrings, absolutely piercings? So one wants to be very conscious of that. This is where we can go back to checking out the equipment, because you might also want to check out the jewelry, and make sure that if people are going to have sex with their piercings, have a discussion about it, whether you're going to keep them in, keep them out, and what the possible risks are. True or false? And please type in your response. Lubricant and using lubricant is a harm reduction strategy. True or false? And some people are writing in T. Everybody's writing in T for true. And one person wrote in absolutely. Now, we do have a couple of falses, and somebody wrote in that it depends. What I can tell you, and remember, we said that a sexual harm reduction strategy is about reducing risk. Somebody wrote in false, not sure. What I want, and somebody writes in, and I'm going to quote them, the wetter the better. Less tearing and reduces risk of transmission. That is absolutely true. Lubricant is a harm reduction strategy. Using lubricant cuts down the possibility of, it does reduce friction, absolutely, cuts down the possibility of of micro tears or tearing of tissues while engaging in vaginal or anal intercourse. So it can absolutely be a harm reduction strategy. So again, these are more strategies, and with that, I'm now going to turn it over to Mary.
Hi everybody, I hope you're enjoying this as much as I am. And I guess a couple of things came to mind when Paul threw out some of those questions. And for example, sometimes your clients may be talking about something and you don't know what they're talking about. Here's the simple answer: ask. I know for those of you who work with adolescents, sometimes just as you think you've learned all of the vernacular, it changes. And Paul and I have kind of a funny example. A friend of ours somebody asked him about a facial. Sorry, it's not funny. Well, it is funny, because he thought that a facial meant when you went to a place and they put stuff on your face and you paid for it at a spa. And what the client was really talking about was having somebody come on their face. So we use that as an example because, oh good, I see LOL, haha. It is interesting because, first of all, we do want to kind of increase our comfort level around it, but sometimes you make mistakes, by the way, but I think to really be genuine is to ask.
And that person was an educator.
And that person was an educator as well. So it just shows that it's easy to not know everything. So maybe later on I'll ask you if you know what a strawberry shortcake is, but hold on to that. Now, here's another list and a continued list of some more. Oh, somebody said, ooh, good, you want to hear about the strawberry shortcake. Cool. Here's another list or a continuation of the list on harm reduction options. And let me just say a couple of things. The good thing is the more options you give people, the better the chances are that they will use them. I know sometimes it's like when you go to a restaurant and the menu is pretty large, sometimes people like that better. So the more options that you can provide with people, for people, the greater their chance of using them. So what we'll be doing is we're going to be going over these with specifically on the slides, but we'll talk about what sero-sorting is. We'll talk about strategic positioning. We'll talk about negotiated safety, viral load calculating, and again, you may know some of these things and not have the fancy terms for them, but we'll get into them. And also, as some of you may know, PEP, post-exposure prophylaxis, as well as PrEP, pre-exposure prophylaxis, which is used with Truvada. So I'm actually going to turn it over to Paul again, and he'll talk about sero-sorting, and remind me again to talk about strawberry shortcake.
You know, it's funny, I remember that incident that Mary just shared with you, and it's so funny as I'm taking this seat, and she said, you know, I'm going to tell you about strawberry shortcake. It kind of makes me think of something that my 10-year-old niece would talk about in terms of like a character on TV, but of course I know that's not what it is when we're talking about sexual harm reduction, but it does sound pretty cartoon-like. So I'm going to talk to you just briefly about sero-sorting. And again, basically, that is a practice of choosing sexual partners based on their HIV status. Now, research has looked at this quite a bit, actually, because it is considered a risk reduction behavior. The data suggests that there may be decreases in the rate of new HIV infections because of sero-sorting. So the data also suggests that the rate of other STIs may increase in frequency, and keeping in mind that if you're sero-sorting, if you're only having sex with people that are the same sero status as you, does not necessarily prevent other STIs, and it also does not prevent reinfection with a new strain of HIV for HIV-positive partners. So folks, why do you think, let's look at that second bullet for a minute, why do you think that other STIs may increase in frequency if people are sero-sorting? Why do you think that would possibly be? Why would other STIs possibly increase in frequency? Yes, people are out, you're absolutely right. People are not using protection. They're less likely to use condoms. People may not use condoms because they don't think they need to. We're both positive. Why would we need to use a condom? Well, it doesn't mean you might not get hepatitis C. It does not mean you might not get gonorrhea. Absolutely. So just to keep in mind in terms of sero-sorting, it is a harm reduction strategy, and I'm now going to turn things back over to Mary, and she is going to talk to you about strategic positioning.
Thanks, Paul. So, as you can see from the slide, we'll talk briefly about strategic positioning. Who has heard of the term strategic positioning before? If you have, please type in a Y. If you haven't, please type in N. Good. Oh, can I speak louder? Yes, I can. So I see a fair amount of N's, a few Y's. How does it increase other STIs if sero-sorting? We'll get to that actually. So let's talk then about what, I'm continuing to look at the Y's and the N's. And again, we're really glad that there's 53 of you out participating in this webinar. So strategic positioning really has to look at, for example, the person living with HIV chooses to take the receptive position. So sometimes it's called the bottom, but the person who is the receiver during unprotected intercourse. Why is this important? Because usually the receptive person is more at risk. So actually, let me throw out a question. Why is the receptive person more at risk? We're talking about sex. Good. So I see tearing of the tissues, yes, because they receive the sexual fluids, they receive the ejaculate. Oh, some of the trauma, again, the tearing. And another thing that I think is also important is somebody wrote that it'll stay inside. So for example, if you're the receptive partner, this is whether you're a man or a woman, that the semen that comes inside will be staying in there. And that's why sometimes people choose when they're looking at strategic positioning to have the person who is already HIV infected become the bottom or the receptive person. So I see that there's lots of answers on that, and I think I'm going to turn it over to Paul again.
So as we think about sero-sorting and strategic positioning, it's important to acknowledge that there are limitations. And I mean, we've already started to identify those. You know, sero-sorting sometimes is sero-guessing and versus sero-knowledge, which means that, you know, I'm looking at your lab work and I know exactly what your results are. The other thing that complicates that is that the window period and the validity of the last test are based on the last risk behavior. So somebody could potentially be in a window period but have a test result from an earlier test that wouldn't speak to sort of maybe what they've done since. We already mentioned this, that exposure to other sexually transmitted infections sometimes is even increased, especially with sero-sorting, and the possibility of reinfection with a new strain of HIV, which is sometimes also called superinfection. So although there is less risk, and again, let's not lose sight of one of the parameters that we talked about with harm reduction, which is small incremental changes that can reduce risk and then what is the word I'm trying to use here? That can culminate or add up or stack up to create larger behavior change. So although there is less risk, and that's a good thing, because that from a harm reduction perspective we want that, there still is risk. So this often makes me think of oral sex. And let me explain what I mean by that. What I mean is that people often will make a choice, and remember we talked about people can make choices about what sexual behaviors they're going to do as a way of reducing their risk. Now somebody may be in the position of choosing, well, do I engage in unprotected oral sex or do I engage in unprotected anal sex? Now please type in, if the person was going to choose unprotected oral sex or unprotected anal sex, which one of those do you think would be the greater risk? People are typing in anal, 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 unprotected anal sex. Yes, absolutely. Now, Mary already went over why that would be a greater risk. But again, from a harm reduction perspective, people are making choices about what is it that I'm going to do or not do. Okay, I'm choosing not to engage in unprotected anal sex, and I am choosing to engage in unprotected oral sex. And again, from a harm reduction perspective, I've reduced my risk. And I've reduced my risk. I have not eliminated it. And that's the key point that we want to make sure that we're all clear on in terms of harm reduction. And I'm now going to turn you back over to Mary.
So we're changing seats and running from seat to seat. And one of the things that I'll talk about now is negotiated safety. Now, some of you may have heard of negotiated safety. And one of the things I think to keep in mind is sometimes people come to you and they have agreements with their partners where, for example, they decide that they will use condoms, that if they have an open relationship, that they won't use condoms at home with each other, but they'll use condoms outside of the relationship. So sometimes you get all kinds of, at least I'm going to say from my experience, all kinds of scenarios around how people negotiate how they live. So as it says there, it's Sero-sorting plus, and again, often between regular partners. And the key is that people have to make agreements about what they're comfortable with and what they're not. I was thinking, for example, that I've worked with or met many people in the training who've told me they've had clients who have, let's say, for example, sex with 3 other people, but it's a closed system, and they have agreements that they will only have sex within that system. They've already been tested for HIV. They know their HIV status, and it works well for them. I guess for those of you who are sports fans, and I'm a big sports fan, is that sometimes, for example, some of the, I guess if I start talking about the NFL or the NBA, I might get to a whole different kind of training, but sometimes, for example, some of the, from what I've heard, is some of the basketball players, some of the football players who have the opportunity to have probably a lot of sex with some of the groupies, usually sometimes have agreements with their partners over the use of condoms or when they can have sex or when they can't have sex. But again, I'm starting to think about domestic violence and all that kind of stuff, so I'm going to actually go to the next slide. So we're going to skip the question because of time, but here's some of the limitations. First of all, you have to have the ability to negotiate. So in an ideal, let's say, relationship, people would be able to talk. They could talk about what their needs are, and as the bullet on the bottom says, they could trust each other. For some people, there's pressure to have sex outside the primary relationship. We've seen that a lot, for example, when a person does not want to have sex outside the relationship, but their partner does, and sometimes they feel coerced into it. And also, they sometimes don't want to wait for testing procedures. The key usually is that you are also want to get HIV tested so that everybody knows everybody's status. I just saw somebody write something in that says talking when you are not right before the act but in downtime. Hey, that's a really good thing, by the way, so that a lot of the negotiation could be done under what's a safer time when people are not getting ready to have sex, but it's part of a relationship where people have good communication skills and they feel safe, and that makes it a lot better. What we do know that other STIs can still be passed. So a lot of things, for example, are not foolproof. But again, going back to what Paul was saying too around harm reduction, we're still not eliminating any risk. We're just lowering the risk. So those are just some of the limitations of negotiated safety. I'm going to say probably from my own experience of training is that sometimes people get shocked by the relationships that people have or some of the negotiated safety issues that people are working with. Let's see, I see somebody just, is Sero-sorting considered harm education? Yes, definitely. Okay, I am going to then, we're doing tag team again. I'm going to change places with Paul and he'll take it away.
Thank you, Mary. So now we're going to talk a little bit about viral load calculating. And I'm just curious, if you've heard of this, can you type in a Y? If you've heard of viral load calculating. I'm seeing a couple of Ys, yes, one no, okay, a couple of Ys, some definite no's, capital N's. Yep, okay, so again, it seems a little bit, I would say, like a 50-50 split. Maybe a few more people not sort of familiar with this. Well, you know something, if you think about that 96% finding that came out of that study, this is somewhat related to that, because basically when someone has an undetectable viral load, well, let me ask a true or false question here, which is T or F. If a person has an undetectable viral load, that means that they don't have any HIV virus. Is that true or false? Yes, it is absolutely false. I did see a couple of trues, and I'm glad that people are being honest and sharing. Some people are saying they're not sure. That is a false statement. If someone has an undetectable viral load, they are still infected with HIV and they are still infectious. The one thing that we can say is that they are less infectious if they have an undetectable viral load than they were prior to having a detectable viral load. So very important to be very clear about that, because some people are very confused about what an undetectable viral load actually means. So it means that there are low or extremely low chances of sexual transmission of HIV if someone has an undetectable viral load. And I want to bring that back to what our colleague typed in earlier about treatment is prevention, because the goal of HIV treatment is to bring down the amount of HIV that is in somebody's body. And if it's brought down to undetectable levels, there's much less virus and they're much less infectious. Somebody writes in, undetectable viral load in our clinic is now less than 20. So again, thank you for that specific marker. And the other thing to keep in mind in regard to that is that the testing has gotten better and the tests are more sensitive. So less than 20 virons per, I believe it's per cubic milliliter of blood, is pretty well managed HIV. And again, less virus, less damage to the body's immune system, more of a chronic manageable illness than a virus that is going to seriously compromise somebody. But again, that's achieving an undetectable viral load. And adherence to HIV treatments is a whole other webinar that we could do, and definitely something that needs to be discussed. Somebody types in, undetectable meant that there's no virus in the semen or vaginal fluid. No, there's just less virus in the semen or the vaginal fluid. That's what it means. I would not say that it means that there's no semen, no virus in the semen or vaginal fluid, just less. So let's walk through very carefully and clearly this chart. So risk of HIV transmission over 100 sex acts during anal sex between men who, where one partner is HIV positive. Now again, this is about sex between men, one of who is HIV positive, the other is not HIV positive. So one is negative, one is positive. This study shows that there is a 60% chance in the HIV negative person getting infected with HIV if they are not using condoms and the person is also not on treatment, so that they have not achieved viral suppression. And again, this is data that is connected to our findings. Now, if you look at the next one, treatment alone, a person who is on treatment alone there's less than 10% that the HIV negative person will become infected. Now, if they use condoms 100% of the time, you'll notice that the percentage is greater that there could be an infection, and treatment actually has more of an effect. And you can see it just slightly in that chart. Somebody writes, please explain second bullet on slide 38, 9 times more infectious. Absolutely. Let me just quickly finish this and then I'll go back to that slide for you. So 100% condom use is less effective, based on the data from this study, than treatment alone. 80% condom use without treatment is even less effective. There's even greater chance that the person will become infected. And if someone is on combined HIV treatment and uses condoms 100% of the time, of course, that's the lowest percentage. Okay? So you'll see how much that 96% of less likelihood is borne out even in this sort of graph form. Now I'm going to return to slide 38. Recently infected 9 times more infectious primary infection than chronic illness. I'm glad you asked for clarification about that. Basically what that means is when someone is recently infected, HIV has gotten into a cell, under their skin, into their blood, and into a cell, and that HIV has started to multiply, the body has no experience with managing HIV. So the amount of HIV virus in a person's body during acute infection is extremely high. So it means there's lots of virus. Now what the body does, and what the body does is so wonderful, is it recognizes the virus and then it creates antibodies to fight the virus. And then the body alone brings the amount of virus way down and really does a great job managing the HIV virus all on its own without treatment. The problem is of course, that the virus attacks the very cells that work together to keep the body healthy. So then the person becomes, their immune system becomes compromised, and they can potentially get some other illness that could potentially be fatal or make them very ill. So the bottom line of that bullet is that someone is much more infectious. That's why it's very important for people to know whether they're infected with HIV, especially when they're first infected. So I'm glad you asked for clarification on that. All right, so I think I am now going to talk about the limitations of viral load calculations. So people generally get tested every 3 to 6 months, but it doesn't mean that they may not have a risk behavior after a particular test when they've gotten a particular result and could be infected with HIV. And again, although there's a very low risk, there is still some degree of risk depending on the activity. Again, oral, there's less risk. Anal and vaginal, there's higher risk. So there are limitations to all of these harm reduction strategies, and that, of course, always has to be factored in and considered. But from a harm reduction perspective, any change, no matter how small, a reduction in harm is beneficial and can lead to greater changes. And I think with that, I am now going to turn it back over to Mary.
All right, so before we talk about PrEP, we're going to talk about PEP, which stands for post-exposure prophylaxis. And as some of you may know, if you work in hospitals and you get a needle stick or blood in your eye or other kinds of situations, that PEP is used. But it's also used for sex. Now here's a couple of things that I think are important. So what happens is if somebody has unprotected sex, and sometimes, for example, it could be the condom broke, it could be that the person wasn't using condoms, that they can start to take medication. And here's the ideal hours, by the way, because people always ask me, how long should you wait? Ideally, by the way, it should be within 2 hours, but not later than 36 hours, because what will happen is, after a while, after more than 36 hours, the medication may not be effective. What we know about PEP is that people will take kind of a cocktail, the 2 to 3 medications for 28 days, and then it's usually followed up by testing 4 to 6 weeks after, 3 months, and 6 months. So it's one of those things I think that can be used. I think what comes to mind too is, though, sometimes when people are using PEP all the time, it may be another issue that you might want to talk to people about, so that they may need a different kind of harm reduction technique. So we're going to go from PEP to PrEP, and I'm going to turn it back to Paul.
So PrEP is pre-exposure prophylaxis, and if you've heard of this, because this has been in the news a lot, and I'm wondering if you are aware of PrEP and you've heard of it, go ahead and type in a Y. Yep, I'm seeing a lot of Ys. Good, and I'm hoping that maybe I'll see 51 Ys. And if there are some, if you haven't heard about it, yes, just had it. A training on it. That's great. Good. So and I do see that there are a couple of people. No, this information is very helpful. Just began my position on Monday. Wonderful. Congratulations. Yeah, so some people actually have not heard of it. More of you actually have than have not. So it's great that we're talking about it. So PrEP is pre-exposure prophylaxis. So this is a daily pill that reduces the risk of being infected. Now, the thing to keep in mind is that it's a medication. It's called Truvada, and it is a pill that people take, and it's an HIV antiviral medication, and studies show that there is a 44% increase in protection for men who have sex with men who also receive other prevention sort of interventions, such as condom use and things like that. And that's, I think, the point of it's not to be used in isolation. So it's not enough to just take the pill, although just taking the pill is a harm reduction strategy. And it is often prescribed for people who are HIV negative and at high risk. So if someone's HIV negative and they're at high risk of HIV infection, what are they doing? If someone is HIV negative and they're at high risk for HIV infection, what are they doing? What behaviors are they engaging in? Okay, MSMs, men who have sex with men, are people who are at risk. Somebody types in, I have a client who is exposed to HIV but does not have insurance. No money to buy the medication. What should he do? I think that there are programs either through the pharmaceutical company and or some social service programs make the drug available, but they should probably start with the pharmaceutical company, because they can sometimes make the drug available. Mary actually wants to add something here.
No, I'm just going to agree with what Paul said.
Oh, thank you. Thanks for agreeing, Mary. So yes, unprotected sex. People are not being abstinent. They're having unprotected sex, engage in high-risk sexual behaviors and or drug use behaviors. Thank you for also including that. having unprotected sex while intoxicated, and somebody writes in that the Ryan White program, I believe, makes these medications available. Yes. Somebody writes in, I have a pharmacy background and most manufacturers offer free offers or will work with people to get their medications to them if they have limited or no insurance. Thank you. I really appreciate you adding that. Programs through Gilead and Merck, info, online, quick response to request for PrEP meds for those who can't pay for them. So it's great. Thank you so much for adding this. Gilead has a great program. And again, Gilead is the pharmaceutical company.